Yes.
Yes, I'm waiting for Dr. Here will join us in just a second. Thank you everyone for inviting us to this session, and especially thank you to Dr. Othman and colleagues. As we can see, based on the previous talks, there's a blurring of the lines between endoscopy and surgery. And I'd like to continue that trend in showing something that really borrows from surgery, also uses other disciplines as well, dermatology, etc., and shows ways in which we in endoscopy, we as gastroenterologists, can go into different fields and different areas where we haven't gone before with great success. So this talk is on endoluminal vacuum therapy in the management of perforations. Professor here will be joining me shortly. So introduction, leaks and perforations, especially of the rectum and esophagus, can be associated with a lot of morbidity and mortality when treated with surgical ripping, which is the general and typical approach when these things occur. Endoscopically, how do we approach this? We have a perforation during a procedure, or we hear about a leak. We tend to think more about clips and stents, as highlighted in a nice review in 2019 by Dr. Othman and Dr. Silak. And the idea is that we want to close these with some of our traditional devices. Over the past few years, however, we've been looking at maybe other ways of assisting with healing. Instead of the typical stent or clips, can we use something else, such as negative pressure wound therapy? Negative pressure wound therapy, as many of you know from medical school residency and training, relates to vacuum-assisted wound closure. So we promote wound healing by approximating the edges of the wound using this vacuum seal. This stimulates tissue remodeling, stimulating blood flow, and decreasing the inflammatory response. The idea is that with this vacuum therapy, we are able, using a mechanical stimulation, as well as decreasing inflammation, to stimulate wound healing. So can we borrow that? Can we use that endoscopically? So in 2004, a few groups began to describe endoscopic placement of this vacuum within the gastrointestinal tract. And initial case series were associated with a dramatic success rate, greater than 90%. I mean, that's fantastic, right? Over the years, a variety of other case series have been published. And it seems that location matters. Now, obviously, these are areas in which we can reach. The esophagus, the rectum, and perhaps a little bit more of the proximal colon, right? We do colonoscopies and upper endoscopy, and maybe a little bit of a small bowel. And success remains high based on these published case series, from 60% all the way up to 100% for some of these small bowel leaks. In some of the newer case series, systematic reviews and meta-analyses, it seems that there's a similar success for iatrogenic perforations compared with our big clips, and maybe even a higher success rate for other types of perforations, such as Boerhaave, and we'll talk about that a little bit later in this talk. And it may be even more effective than covered stents for some of the anastomotic leaks, which our surgeons tend to refer to us or have us help with. What are the indications then? Perforations or anastomotic leaks, as we talked about, in areas accessible by the endoscope. It makes sense. What are the contraindications? Now we can think if there's already a stricture, it may be difficult to position that sponge. So that is one of the relative contraindications. Varices may increase the risk of bleeding, especially in the esophagus. So another, perhaps more absolute contraindication. If you can't maintain the seal, it doesn't make any sense. So that's a contraindication. If there's a decent vessel near or at the site, you worry significantly about bleeding, especially when you apply the negative pressure. So that is another contraindication. If there's clinical instability or very large defects or chronic leaks, as Dr. Here will talk about a little bit later, those are relative contraindications. We still sometimes will use this, especially if there is no alternative, especially if the patient is a poor surgical candidate. Now, how do we do it? And I'll turn it over to Dr. Here in a little bit to describe these two slides. But essentially, we use the wound vac machine and we modify it so that we're able to place the vacuum suction at the site of the leak. If Dr. Here wants to describe this slide here, we're placing it within the cavity.
Sure. So once we identify the area that we want to place the EndoVAC, we will come back outside of the patient and set up our sponge that has to be trimmed to a reasonable size sort of somewhat based upon the defect or the lumen that you're working within. Then we'll attach a suture to that to facilitate the placement of it. And we will essentially drag it alongside of the scope as we go back down, and then attempt to leave the sponge, which is attached to your NG tube, in the appropriate location next to the defect. So you can see here in the picture that's described. Usually once we have it into the location that we want, we'll turn on the vacuum to help it stay in place when we remove the scope. And there are sort of two options for placement. What's shown here in the slides is basically placement within the defect itself. The other option is leaving it, as you can see on the next slide, adjacent to the defect. And that somewhat, again, depends upon the location, the size, and what you're really feasible that you can do when you're performing the procedure. And same plan here, you turn the suction on when you have it in the right spot, then you're going to remove your scope and leave it there for several days.
And then putting all this together, and I like to try to play this video here.
Highlighted a linear perforation above the G junction at approximately 11 o'clock. Given this, we decided to proceed with EndoVAC therapy. This slide shows the equipment needed for successful EndoVAC procedure therapy. We will now demonstrate how to assemble the EndoVAC equipment. This video shows the supplies and the wound-vac machine required for setup. This is the tubing attached to the machine. This is the standard NG tube.
You're on the pilot for 5 minutes.
And this is the wound-vac sponge. Initially, the NG tube is placed through the ears and retrieved out of the mouth with the help of the manual forceps. There are holes at the end of the NG tube, and we favor a short segment of holes. Hence, we cut part of the tip. The wound-vac sponge is then cut to a size that will fill the cavity for the perforation.
Dr. Ketwaroo, we can't hear the video now. If you can just comment on this.
So in the interest of time, here we have basically the placement here, and the sponge is being placed, and based on our description. And just to highlight this particular patient, afterwards you can see the beautiful granulation tissue and beautiful healing. and then the follow-up CT scan and radiographic images that show complete healing of the Boerhaaves. Adverse
Dr.
events.
Osman, we have a question.
Sure, yes.
Do you introduce the Ryle tube beside the scope, or through at first, or you advance the scope first? How do you introduce the sponge with the Ryle tube?
So, we initially do our typical exam of the area and plan out what we want to do, and then we'll come back out and then drag the sponge attached to the NG tube down with the scope, usually by grasping a suture with something like a rat tooth forceps and carrying it down that way.
So grasping it on the outside here,
Yeah.
as you can see, and then taking it into the patient. Perfect. And in terms of adverse events, I'll turn to the doctor here. Let's briefly chat about that.
So, certainly malnutrition, which is sort of an issue built into the original problem, but you want to look towards some form of alternative feeding, PEG, PEG-J, or if absolutely necessary, TPN. Additionally, you can have EndoVAC sponge. By purpose, it's going to be right there and can somewhat adhere to the mucosa. This can cause some irritation and bleeding that area. So when we go back in to remove the sponge, we really irrigate copiously with water to facilitate removal. And then we prevent kind of more significant bleeding, usually by replacing it on a more frequent basis, every 3 to 4 days, or sometimes slightly longer. But this will prevent, in most cases, major episodes of bleeding, but of course, certainly can happen. Again, during the removal, you can have bleeding, and this is treated with sort of your standard hemostatic approach. We haven't had a whole lot of that in general. Next up would be a sponge, either dislocation or migration. And that you would imagine could be worse depending on somewhat on the location or the anatomical direction, so to speak, that you're positioning in. Next would be something of a stricture. Possible, some of these are somewhat theoretical or ones that we haven't encountered frequently, but the idea is just to give you some idea. And then just always keep in mind, this could be a very prolonged hospitalization stay. In these patients, the alternative would be the exact same, either way. But just to keep in mind that you'll have to replace this pretty frequently, and that can often require a long stay in the hospital, on average, something like a couple of months.
And then finally, in summary, EndoVAC therapy represents a very minimally invasive or more minimally invasive approach to managing perforations and leaks. It has the potential for significant improvement in morbidity, mortality, and potentially costs compared with surgical management. And we as gastroenterologists need to be aware of this approach, as we are probably best trained to place the EndoVAC as part of a multidisciplinary team. Thank you all for inviting us to speak today.
Thank you. It's a beautiful lecture by Dr. Ketwaroo. I want to say a comment that I was in Egypt in November in Al-Ainy hospital, and we had a patient who required that technique, and it was really easy to get the EndoVAC. So actually, the surgeon was there. We told him we need EndoVAC. Said, "Oh yes."